What everybody wants is better health for people, and I think that medicine and public health do tend to approach it a little differently. Medicine is much more oriented towards the individual patient, and public health is oriented towards, I guess, the community or populations. You're not going to succeed in gaining better health without really looking at both sides of that equation.
These partnerships are so important because reaching a population of people with an intervention, it takes a certain amount of organization and certain things that have to fall into place. Reaching individuals with interventions is something that happens in a clinic setting, and although they both may have the same goal, the methods are very different.
Partnerships are very important between private doctor's offices and health departments because there's a gap. There are many areas where patients need extra assistance and aren't going to get it from my time in the office. So I may have 10 or 15 minutes to talk to a patient or a family about healthy lifestyles, healthy choices, but that just doesn't go very far sometimes.
I think that as physicians we tend to fix things that are already broken, and the public health standpoint is more of prevention and making sure that things don't get broken in the first place. And the first line are going to be your primary care physician. So I think that it's the health department's job to identify the areas of need and to work with and collaborate with these local physicians.
The local health department often has resources and access to resources that we don't have in the private office. I think they can disperse information and gather information from a broader population than we can here.
Probably the thing that I liked most about working with public health when I was in practice was that it provided a system. It provided a lot of support for me, and to be very honest, they provided a whole lot of people who could get things done that I was interested in seeing have done, but that I really had no resources to draw from to make that happen.
Clinicians now have so many things to do in a short period of time in a clinical setting, and going to a physician or a healthcare provider and saying, will you do one more thing? We just need you to do one more thing on top of everything else you're doing. It's a hard sell, it's difficult, and it's understandable that it's difficult to do that.
I'm Dr. Marcus Plescia. I work in the North Carolina Division of Public Health, where I oversee all of the chronic disease and injury programs that we run through the State Health Department. I think a really good example where public health and primary care partnerships have worked very well is in Wilkes County, North Carolina.
My name's Beth Lovett. I'm the local health director in Wilkes County, North Carolina. Two of our most successful partnerships in Wilkes County and two of the most important partnerships in Wilkes County right now are the Energize project that works with kids at risk for type 2 diabetes, and the Chronic Pain Management Project, which is a collaboration under the Community Care Network that we are a part of. The Energize program is a great opportunity that we had through grant writing, but we stumbled upon it initially in a quest. We had done BMI studies in our middle schools, starting with 6th graders. Unfortunately, we found that in our 6th grade classrooms, we had over 50% of our students either overweight or at risk for being overweight. And so Energize was one opportunity that we were fortunate to bring to Wilkes County to help support a small group of those kids. But more than the statistics, these are real kids, real life, and they are suffering in a way that we have not seen in generations prior. This is the first generation of kids that will likely not live as long as our generation because of the problems with childhood obesity. The Energize program is an intense 12-week program for children and their families. They commit to coming to classes at the Y 3 times a week for that 12 weeks, and it's a combination of education, behavioral modification, and exercise. So this is an evidence-based, multidisciplinary approach, and it's proven to work.
My name is Dr. Julie Koch. I'm a pediatrician, and I work in North Wilkesboro, North Carolina at Wilkes Pediatrics Clinic. The children that I'm referring to the Energize program are those who have a significant weight problem. Their BMI, body mass index, is greater than the 85th percentile for their age. We've had very little success with just talking to the family, lecturing the parents, lecturing the patient. It just hasn't been successful. And many patients have requested help with something in the community. So this is a great place for us to refer our patients. There's very little work on our end aside from just getting some information together for the coordinator at the health department, who then takes over and gets the family and the patient involved. Basically, if I have a child that I see who has a weight problem and they're interested in having some assistance or being part of a program, I will refer them to the Energize program at the health department by simply filling out a form. There's a form that's already basically has all the information that I need, and I just fill in the blanks on the patient's weight and height, blood pressure, demographics, and then I either call the coordinator or fax that to the health department, and then they contact the family.
What's fun about this program?
I want to exercise.
I get to run.
Yeah.
I get to do crunches.
I think the most fun part of Energize is that they make games out of exercising, so it's not just like you're running a mile, you're actually you're playing games as you're running the mile.
What's fun about the Energize program is that you get to work with friends, you get to be happy, everybody's nice to you, and you have a whole lot of fun.
The challenges that the patients face that I'm sending to the Energize program are essentially that they've been trying for years on their own to lose weight or to control their weight and have been unsuccessful. Many times it's the entire family that has a weight issue. It's just habits that have been ingrained for years as far as the way they're eating, the types of foods they're eating, the amount of activity that they're doing. I think that is probably the biggest challenge for the patient, is it's very difficult to do on their own, so it needs to be a group effort for the family and then others in the community. In the health department, and the coordinators for this program really work with the entire family.
My name is Marty Lanning. My son is Anthony Wade. He's 11 years old. He sees other children getting picked on like this, and he doesn't want to have that problem. He told me the other day he wants to take care of the problem before it gets to be a problem. So it was really him who taught me into it more than anything.
Yes, I'm Barbara Lowe, and my child's name that's in the program is Stephanie Lowe. Energize program's awesome. It gets them active, it gets them excited, it gets them moving, they make new friends. And I feel like these friends are going to be lasting.
Many of these children are challenged socially because they are not welcomed into certain peer groups because of their weight, and they have poor self-esteem both from the fact that they've had difficulty with weight gain as well as not being invited in many social circles and often facing ridicule and scorn. The great thing about the program is that it is not just the patient and the family involved, but they're involved with peers facing the same problems and issues, so it's a very supportive environment.
I think the Energize program is the greatest thing that's ever happened to me.
I think the Energize program's a good thing, but it's probably not the greatest thing that's ever happened to me.
Hopefully when the grant money runs out, we'll have enough of a motivated community to figure out how to keep offering this important service for the kids. The Chronic Pain Initiative is quite a different project for Wilkes County. This was born through a combination of things. Again, one was statistics. We do a lot in public health with statistics. They're important and they ground us to pick out priorities. This particular statistic is that in our community, we have folks who live here dying at a rate of 4 times North Carolina's average of unintentional deaths due to prescription drug overdoses. We had a substance abuse task force working on that, but quickly came to realize that a part of it was rooted in chronic pain. And we worked with our community care network, of which we are a part, and as are our local primary care physicians. And so through that network, we've been able to put together a chronic pain management pilot. And Dr. Sue Albert has been the lead of that project, and she has been our real link to the medical community.
As County Medical Director for the Community Care Program, I have had a lot of face time with our local primary care physicians, and for this project I'm really a liaison between the project and the physicians.
It doesn't just involve the health department and doctors, it involves our entire community. We've had participation from the Substance Abuse Task Force where folks are there who've lost loved ones due to unintentional drug overdoses. We also have the school system involved with us in terms of education. We have the faith community. We're working now on a presentation that can be used in civic groups and in churches to really raise awareness for folks of those issues.
We've worked with the local hospital to try to work on the emergency departments and decreasing narcotic prescriptions as we can. We've worked with the physicians physicians' offices on best practices for the treatment of chronic pain. We have worked with our local health department and the Community Care Network of North Carolina Medicaid program with this. We have pharmacists that are looking at narcotic prescription patterns and helping us to identify abuse and diversion patterns. I feel very passionately about the treatment of chronic pain because I think that the problem with overdose is a big one, but it also tends to scare people about prescribing narcotics, which leaves a whole lot of people with legitimate chronic pain without adequate treatment. It's been embraced. I think that everybody sees that this is a problem in our county, and even though they know that the issue of treating chronic pain is a big one here, they're not aware of the statistics on accidental overdose deaths. And so I think when we start the meetings with those statistics, we really get their attention. And across the board, the project has been embraced.
Good partnerships are going to be about good leadership. And so I think when you have physician leaders who do see the importance of looking outside of the walls of their clinic, that makes a huge difference.
My name's Dr. Joe Fesperman. I'm a board-certified family physician. I work here at Wilkes Family Health Center in North Wilkesboro, North Carolina, and I've been a physician here for 27 years. Instead of just saying, here, take this prescription, you can begin to interact with the patient saying, let's see if we can really try to quantify how severe your pain is and how it's affecting your life. And then we have checklists and stuff that we can use to try to intervene using various medications and help them rate the improvement or lack of improvement in their symptoms. It also encourages us, of course, to try to keep good track of our medications so that we know our patients aren't getting their prescriptions filled too early and aren't abusing the prescription process. The other thing they've done is arrange continuing education meetings here in the county, and they have brought in one of the physicians who's actually a pain specialist in the county so that we could enter into dialogue with that consultant. I think the impact the initiative will have on practices is to give physicians more confidence in dealing with this increasingly difficult problem, and perhaps will allow physicians to be open to taking care of these folks rather than shunting them specifically to specialists, perhaps keeping them out of places who are simply pill mills that are happy to give them whatever they want. And I think it will help keep physicians honest in thinking about the different types of pain and exploring a wide variety of issues, both pharmacologic and non-pharmacologic, in treating the problem.
Partnering with local physicians is a challenge, and part of it is because I think that in respect for the physician's time, folks like me sometimes will err on the side of saying, well, they're too busy. They've got busy practices, they don't really have time for us. But actually I find myself having to push myself out of my comfort zone, take a deep breath, give them a call, walk up to them at church or in the community or on the Greenway and talk about these public health initiatives and just kind of remind them about public health and their part of being successful with the public's health.
I think a really good example of a collaboration at the state level is our experience with the North Carolina Tobacco Use Quit line.
I'm Sally Herndon-Malick, and I'm head of the Tobacco Prevention and Control Branch in the North Carolina Division of Public Health. Tobacco use is the leading preventable cause of death in North Carolina and the nation. Currently, about 22% of North Carolinians smoke. Last year, 57% of North Carolinians made a serious but failed quit attempt. Tobacco use costs North Carolina $2.7 billion per year in excess medical costs alone. This also contributes to a $769 million tab for our Medicaid program. These are preventable healthcare costs that we can avoid by helping tobacco users quit. The North Carolina Tobacco Use Quit line is administered out of the North Carolina Division of Public Health with funding from CDC and state government and from the Health and Wellness Trust Fund.
I'm Jana Johnson. I'm a physician and am the former medical director for the Tobacco Prevention and Control Branch at North Carolina DHHS. North Carolina Quit Line was launched in November of 2005, and since that time has served over 13,000 North Carolinians. It's a telephone-based cessation program that's staffed by professionally trained quit coaches that are able to assist tobacco users through the entire quitting process. The fax referral program is a wonderful way to reach tobacco users that are ready to quit but not quite ready to pick up the phone and make the call themselves. It can be initiated by anyone who's working with a tobacco user. It does not have to be a healthcare provider. But for example, a tobacco user may go to their clinic, talk with their healthcare provider about quitting. We hope that that provider may give them brief advice to quit. That's an evidence-based intervention. And ask the tobacco user if they are interested in having the quit line call them. If they are, the tobacco user signs a form giving the quit line permission to call them, indicates times that would be good for them to be called, and the healthcare provider then faxes that to the quit line. The quit line, a quit coach, will then call the tobacco user at times that are indicated on there that are good for them. And at that time, once they reach the tobacco user, the same options are available to them. They can either have a session then and there. They can enroll in the proactive quit line service, which means the quit coaches can call them back at different intervals. But again, once they are contacted through fax referral, they have the same options to go through the entire quitting process as if they picked up the phone themselves.
My name is Tom Marsland. I'm a physician at Highgate Family Medicine in Durham, North Carolina. What we do is we explain the quit line, and most people are very interested in trying it. We fill out patient information, demographics, identify a time when they would like to be contacted by the quit line, have them provide the number where they are going to be most easily reached, and then they hand it to our checkout person at the front desk who faxes it to the quit line, and that's it. It's very simple.
My name is Sarah Elizabeth McCauley. I'm 24 years old and I go to NC State. I started smoking, I believe, the summer before my 6th grade year. I was 22 when I quit, and for a 22-year-old to not be able to get up the stairs without having to stop halfway to catch my breath, that really was pretty scary. I knew that I had to do something. I didn't know how I was going to do it. I had gotten to know this doctor fairly well. She wanted me to quit because she cared about me, you know, as a person, and wanted me to take care of myself. And that's when she gave me the quit packet.
People that receive that advice from their healthcare provider are much more likely to quit for good. So if they've received that advice literally 1 to 2 minutes, no more than that, and then use the quit line, they're statistically much more significantly able to quit than if they don't get that advice or don't use the quit line.
The quit line in particular is helpful because I don't smoke, and it's a little harder for me as a non-smoker to identify. And as I understand it, a lot of the people who do man the quit line are former smokers, and so they can provide that kind of personal experience part of it to help people that can understand and empathize much more effectively than I can.
When I spoke to the person, the first person that I talked to, I said, "Now I'm not thinking about quitting. I wanted to make sure they knew that I wasn't ready to quit yet. They knew exactly what to do, and they said, "Well, why don't we just go ahead and set you up a profile so that, just in case you decide to call back again, we'll already have your information." And I think if they had told me, "I think you should quit today," or "I think you should quit tomorrow," I would have said, "Oh, thank you very much, I'll talk to you later." But the fact that they sort of gave me, a month and said, "Well, how about 30 days from now?" That was something that I could picture. They said, "Well, what's holding you back from quitting?" And I sort of listed those things, and they said, "Well, what if we gave you lots of different tips and suggestions to be able to deal with all those things?" And once they said that, it was like, oh, well, maybe I would be able to quit. As long as I listened to them, as long as I talked to them, it was like I felt like I could actually quit. I felt like quitting would be possible. Since I quit smoking, I feel like I have given myself a better chance at having a healthier life and living longer and just being healthy overall. I just feel so much better.
I've talked to a lot of healthcare providers about the quit line and about its effectiveness. And I think the biggest resistance that I've seen and heard about is that physicians just have a hard time fitting in an extra thing to do. And what I would say to that is, if you spend an extra 1 to 2 minutes helping your patient quit using tobacco by giving them that advice and giving them the information about the quit line, you have provided an evidence-based intervention. And as physicians, there aren't a lot of things that we can do in a short period of time that are evidence-based, but that's one of them.
The North Carolina Tobacco Use Quit Line, combined with medications, can double the success rates of people who are trying to quit.
The public health leaders who do best with these kinds of partnerships are the ones who have a real strong health promotion background and interest.
With public health as the cheerleader, that's kind of what I have called us, as the cheerleader, we can make a difference and engage the rest of our community.
The health department can better help me by developing checklists and efficient ways to do my job better. I need to have things as organized as possible because you have relatively little time with each patient you see, perhaps 7 minutes. They need to come back and say, is this working? Is this not working? What do we need to do? The other thing that would be great then, of course, is if they had some outreach into the office. They've got physicians here, but what if somebody from the health department was, putting it in place, or at least here when we were trying to use it?
Physicians have an enormous amount of credibility in our society, whether it's at the local level or state level or national level. And so I think from the public health leadership side, you've got to look for a way to bring that forward and make use of that and really provide opportunities for physicians to be spokespeople for the work that you're doing.